Hi everyone, my name is Rachel Moses and I'm a consultant respiratory physiotherapist and I'm working in a Chief Allied Health Professional role at the moment. And I'm delighted today to be joined by three incredible physiotherapists who are going to be talking about all things post-COVID ICU recovery and rehabilitation. So this is a series of podcasts with numerous different subject titles, and as per every single one, we do have a slight disclaimer in the fact that people have volunteered to talk in their own time. It's a Sunday evening, and they've been very brave because they're talking about their own lived experiences and what they've found in practice. And that can be people working, at the coalface or in more academic roles or in more research roles. And it's really important we bring everyone together to say, actually, we don't know a lot about this disease post-critical care phase. We're learning all the time, and what can we kind of learn together about? So we're really grateful. It's not the best, it's not the only way to do anything, it's just what we have experienced. So to introduce the panel, to my left is Bronwen Connolly. I'm sure many of you know who she is. She's an absolute ICU Rehab legend and guru, and she's currently working as a senior lecturer in critical care at Queen's University Belfast. To my bottom left is Zoe, who's clinical lead and physiotherapist in general ICU in the University Hospitals of Southampton, and has been doing some incredible work across acute and long-term pathways. And Kelly Morris, lovely Kelly, clinical specialist physiotherapist in critical care at Guy's and St Thomas's Hospital and ICU extraordinaire. So I feel like I've given you all the credentials that you need to get started. So I'm going to start off by just setting the scene a little bit here, and the fact that this is such a new disease. Okay, this has been, first presented at the very back end of December, January, and hit the UK in March this year. So we have assumptions that we're making on what these patients require post-critical care, and some of that is on the observed rehab needs that they have on discharge. But actually we can extrapolate a lot of similarities and a lot of data from what we know about post-critical care rehab and recovery that already exists. And as I've talked about in some of the other podcasts, is we've had guidelines and we've had number ideas and staffing ratios and what the needs of critical care patients are for a number of years now, from experts in the field, people like Bronwen working on this and researching this, but we've yet to meet kind of guidelines and standards of care for these patients group irrespective of COVID. So Bronwen, I'm going to come to you first, because you've been working tremendously hard, not just nationally but internationally, to understand from colleagues in other countries and from your own experience of post-critical care rehab needs about what these patients might need. So do you want to kick off by first of all just telling us a little bit about the work you've been doing and what you found?
Great, thanks Rachel, and it's great to be part of this podcast. So thanks for having me on board. So I mean, this is, as you said, this is a new disease, and we're learning as we go with these patients in terms of how they present, how they might be similar to the kind of typical, or inverted commas typical, non-COVID ICU patients that we see, and what we can learn from our prior experience and from our partners around the world. Many of you will have come across the term post-intensive care syndrome. That's pretty well established in managing post-ICU patients. And I think we need to think about that in terms of some of the key problems that patients will face. And that's a term that encompasses physical, cognitive, mental health domains of impairment. But actually we know it's even far more than that now. And if we were to define that, it would include things like swallow, communication, nutrition, and many other aspects of recovery. But also, as patients move through the kind of the post-ICU discharge stages into the community, it's things like how they return to work, how they reintegrate into society, how do they resume their normal roles in society and participatory activities. So I think we need to look at patients in that truly holistic sense about trying to understand what are all of the different types of problems that they might face. And one of the challenges with our ICU population is that no two patients are the same. All of our patients are completely individual. So what what one person presents with and the severity of symptoms that one person presents with is completely different to another patient, not only in terms of their demographics, the age, the gender, their prior medical history, etc., but just the individual problems that they might face. And that's definitely been something I think that's challenged us in the past, trying to look at rehabilitation for these patients, is how do we tackle a very individual population with trying to look at rehabilitation interventions that might try and fit all, and it just isn't possible. We need to have mechanisms by which to individualize our assessment of their post ICU rehab needs. And so picking up on some of the work that we've been looking at internationally, I've been working with colleagues linked in with the WHO, but and also other colleagues who have been researching and looking into post-ICU survivorship for many years. And it's, you know, all of these patients are very similar wherever you go. There's typical features, there's commonalities in the symptoms that they're presenting with, but obviously, you know, thinking with the international hat on, the healthcare settings that we treat these patients in is very different. So we need to be mindful of that in terms of how we set up systems and infrastructure. And that's certainly been something that I've learned a huge amount about recently, how to kind of put that into perspective in local settings that aren't first world settings. But definitely there's a lot that we can share with our international colleagues around this, because these patients, you know, the types of problems these patients experience are very similar. But I think in terms of how we start to understand effective rehabilitation interventions, it's about understanding the individualized problems that patients experience.
Fantastic. So we know that post-intensive care syndrome exists. We know that generally, I'm generalising here, it's very difficult to meet the needs in our existing healthcare system and with rehab pathways and rehab teams and what rehab looks like. And consistently across the podcast, one model doesn't fit all. It never does in healthcare unless it's certain surgical procedures, for example. So it's really challenging. And Zoe, if I bring you in at this point and talk about some of the predicted, probably short-term rehab need. We can hypothesize about the longer term, but what can we categorically say from COVID, post-ICU COVID patients, to some degree non-ICU, but think about the ICU population at the minute. What specific rehab needs do they have that you've seen in clinical practice?
So I would echo everything Bronwen said in terms of their commonalities, but also they unfortunately, right at the beginning, we said, brilliant, we've got one disease, this is going to be easy, but actually they're a massive mixed bag. We've had 33-year-olds who are still with us 55 days later. We've had 76-year-olds who've managed to stave off intubation, have gone home, you know, walking. So it's been really challenging, even within one disease, trying to work out and predict what rehab needs these patients might have. In terms of physical needs, we talked about it earlier, they take two paths. They're either the patient who is extubated and walks home, or they're the patient who gets a tracheostomy, is going to be very long term with their ITU acquired weakness. And there's not much in between, to be fair. It's the non-physical, I think, that's really interesting with the COVID patients. They are all very, very, very delirious, and it's a very different delirium to anything we've seen before. And I think that's probably multifactorial. That's because of the waking up from benzodiazepines that we haven't used for years. We're all wearing PPE, which is scary. We talked about earlier where we're surging to. Our patients are on PICU, so they're seeing giraffes on the wall when they wake up, which is scary in itself. And of course, not having family in to orientate you is a massive factor. And we're finding actually, even going throughout the pathway, acute, subacute and beyond, that missing family, such a massive part of your rehab involves your family. The men, for example, and a lot of these patients are men, obviously, don't have the reassuring wife at the bedside, or the sensible word of the wife who says, I'm not having you home like this. You know, they're ringing them and saying, I'm fine, I'll come home. And these patients will do anything to get home. They will crawl home if they can get there. So they're not being referred to inpatient rehab because they're refusing it, because they just want to go home. And then they will go home and no doubt, and I'm sure Kelly will be able to expand on this, is that they're then finding themselves in a bit of a heap when they get there. And I think this is going to be the burden for community services moving forward.
Absolutely. So in terms of physiology, we have a group of patients who have had a terrible respiratory disease that has required them to need invasive intubation, sometimes with a tracheostomy, sometimes without. They've had particularly nasty lung injury that they recover with normally quite severe hypoxemia associated with that. They then have ongoing refractory breathlessness. They then have ongoing diaphragmatic and muscle fatigue. They then, on top of that, develop nutritional complexities, which we've talked about in the other podcasts. And then that results in what can only be predicted as reduced muscle mass, which is, again, complex to define. And then on top of that, they have this fatigue. And then on top of that, we have the psychology and the psychological trauma, the separation, and then the engagement with rehab because of the obvious barriers with PPE, the obvious barriers with engagement about the population of patients we're seeing in terms of age and sex and not having the normal drives for rehabilitation. So actually, when we talk about this patient group, it's very hard to then fit into those existing models. And Kelly, I'm going to come to you before coming to Bronwen. In terms of what you are seeing, in terms of me just summarising that up, is that exactly what you're seeing within your cohort of patients as well, in terms of their post-acute needs and those post-acute problems that we're seeing?
So I've done one COVID clinic where we saw 9 patients. And from that, I've been able to sort of pull through some really clear impairments that we're seeing that, 6 or 7 of those patients were experiencing. And like you said, there are just so many different categories from that. When we think about it from a physical point of view, it's the breathlessness that you were describing that they still have at home. And they talk about that in terms of, minimal activities of daily living. And like you said, these are 30, 40-year-old people at home that are now struggling with their, just to be able to walk around the house having breathlessness. The cough side of things hasn't been so prevalent. I've only seen that in a couple of patients where they're still having issues with cough, but that is another impairment that we're seeing. They all talk about their reduction in exercise tolerance and their fatigue levels. And again, this is what's really interesting, because you've got a group of young people generally who normally go out and do exercise. So they've got the limitation of that. They then, because of lockdown and everything, normal pathways that we'd utilise and normal advice that would be used with these patients, we therefore can't use. You've got people that have developed new musculoskeletal problems again. So 5 out of the 9 patients that I saw had a new musculoskeletal problem. We're obviously a bit more worried about the incidence of shoulder injuries because of proning as well in these patients. So it's something that we're having to look at. And then you've got obviously their reduction in function, and you touched on it from a work point of view, a home point of view, all of those aspects. And the psychological impact is obviously huge. Patients have been really emotional on the phone calls when they're talking about this. And I think the other thing is the swallow issues. We're really seeing quite a lot of people that are saying, when I'm eating solid foods, I'm really struggling from a swallow point of view. So they're the sort of main impairments that I would say I've picked up on so far.
Okay, that's great. I'm going to come back to your dysphagia, your swallow comments in a second. But Bron, if I can bring you in at this stage in terms of any comments about the complexities and what we're seeing.
Yeah, thanks. Actually, Zoe and Kelly both picked up. I was going to ask about the breathlessness and the fatigue, which I think have been, lots of other colleagues have flagged that up as being particularly acute for these patients, perhaps compared to general ICU patients, and certainly those problems. So it's just that they've both mentioned that. We're learning more and more about this condition as we go, and the kind of severity of respiratory failure that goes with it. And I think that's the trigger for a lot of these problems, and that all of our ICU patients are complex in their individual needs. I think that the fact with COVID is that we've got all of these other external factors in play. So we've got, as Zoe was saying, the fact that clinicians are in PPE, we've got a different environment without family, we've got the pathway that means that's existing services that we might be able to access, and different support at home that we might normally try and access for ICU patients isn't there. As Kelly was saying, the advice that we might normally give to patients is, they're going home into what is a really weird time for all of us, and if you're an ICU survivor of this serious illness, then going home and trying to readapt to your new normal when society is not normal in any way, shape or form at the moment must be completely bewildering for these patients. So I think we've got to, that will be the challenge as we try and identify what could be rehab pathways for these patients, is actually all of these external factors that we can't really control either. So we don't know when the restrictions will be relieved completely, or whether that's going to be geographically different. And how long those might be in place for. So all of those things are kind of, I suppose, limiting our normal decision-making processes, because we can't kind of use all of that toolbox that we might normally have for factors that we can't really control. So I think that's going to be the kind of added external complexity for these patients.
Absolutely. And I think one of the challenges is we have ideas about what an ideal post-ICU rehab recovery pathway model would look like. The reality is, have we ever managed to get that adopted on a national scale before in the last over 10 years since people like you guys wrote the guidelines? And the answer is no. And now I think it's fair to say there's a slight frustration amongst the kind of therapy community, as well as a relief that there's so much interest in rehab pathways now, and everyone's got an opinion on it. And it's great that our fellow medics are really excited about these pathways, and that can help us achieve things that we've been trying to achieve for decades now. But that adds another complexity, doesn't it? Because the way the commissioning works, the way that services are set up across STPs, across integrated care systems, different commissioning models, and then the challenges we have anything to get adopted at national level, it is difficult, especially in the speed of time we need to develop these pathways. So Zoe, I know you've been doing some work around this from a local perspective, and then Bronwen, I'll maybe come back to you in terms of a national perspective, but where do you even start about thinking, right, yes, we haven't quite got our post-ICU recovery pathway right, but we've got this cohort of patient, everything that Kelly says, younger patients, they need to get back to work, they've got families. If we don't get it right now, the consequences of this disease is it's only going to get worse and worse if we don't help them rehabilitate now. What have you been doing locally to try and address that in terms of your pathways?
Well, so at the end of last year, we were able to secure a tiny amount of funding to run a small post-ICU rehabilitation class, which is not a new idea. We've wanted to do it for a really long time. It was only 8 patients over 8 weeks, and they came in and they had their exercise, and they came with their families, and their families had some separate peer support. They had some peer support too. We had people from ITU coming down, pharmacists, dietitians, speech and language therapists, and it was such a resounding success, and it was so good to see, and it was so good to prove that we could have a 19-year-old polytrauma in a room with a 96-year-old pneumonia, and their families would get something out of it and they would get something out of it, and it was brilliant. And so just pre-COVID, we were at a point where we were looking at a sort of a whole system approach to this post-ITU recovery, and how, yeah, all right, ITU shouldn't have to pay for everything, and perhaps, the GP should come in like they have at St Thomas's, and it should be a bit of a more joined up thinking. Obviously everything went out the window with COVID, and that's fine, everything was put to one side, but just having that experience and now seeing the push for rehab has been really helpful, because we were actually presented with a bit of an opportunity during the particularly spicy week, as one of the consultant calls it, around PPE, where we were deemed, there was no PPE and we weren't as essential as the nurses. So I had a gazillion people redeployed to me to go into ITU, but because of PPE, we weren't allowed to go in, basically. So what we decided to do is that we decided we would try and tackle the ward part of the pathway that we'd never been able to tackle before. So we started our what we call Restore project, which is basically ward visits. And it just, you know, it's about information provision and giving out the leaflet and talking through the symptoms that patients might experience, because so much of what they told us in that exercise program was, if only you'd told me I was going to feel like this. And it seemed like, you know, it doesn't have to be rocket science. It doesn't have to be an amazing, expensive proposal that we're asking people to fund. A lot of it is talking therapy. I appreciate there are other things as well, but a lot of it is talking therapy. So we're trying to address some of those issues on the ward early. And some of the guidance that came out this week, there was a lot of guidance that came out this week around rehab, talked about how it's important to have ITU staff involved from the beginning all the way through, and how actually tackling some of these issues before people even go home will reduce some of the burden in the community. So that's what we've been doing, and it's been great, and we will repeat the visits as many times as we need to try and get that message across, and trying to manage some expectations before people go home.
Brilliant. No, and I think that is, again, a bit of a common theme. So when we talked to the psychologists, and when we talked to, when we were talking about the sexual health chat, sometimes people just need to be told it is normal to experience this, it is normal to feel this, and if you still feel this, then you need to get help. Now that can be signposted, you can do that on discharge, or if you do review them, but I think that's a really powerful point you've just made there, and you can get that bit right from the start. That doesn't take a lot of planning, does it? So Kelly, I'm going to bring you in at this stage, because you do work at a centre who has very well adopted post-ICU pathways, and I know Bronwen used to work at Guy's and St Thomas's as well. So you have these pre-existing pathways and clinics, and you have now developed some innovative ways of help managing these patients. Do you want to tell us a little bit about what you've been doing and what you've achieved?
Yeah, thank you. So we had this clinic running beforehand, and the criteria for accessing this clinic was mechanical ventilation for longer than for 72 hours or more, ICU delirium, have been on ECMO, or have an IPAT score of more than 7. So that's the intensive care physiological assessment tool. So that was the criteria before for being referred into our follow-up clinic. And you'd generally come and see us for 8 to 12 weeks, after you've been discharged home. And during that clinic, it's an MDT clinic, uses like a carousel system. So they come in, we'll see the nursing staff, have their observations done, start filling in some questionnaires. And then depending on staff availability and how the patient's presenting, that will be the order that they go and see people. And we are so lucky, they see a consultant, they will see a psychologist, and if it's felt they need neuropsychiatry input as well, then they can see a neuropsychiatrist. Myself and the occupational therapist will carry out a joint session. The pharmacist has already reviewed all of their medications before they come to clinic, and then if we need support from our speech and language therapist, that's an extra referral. They're not actually in clinic at the moment. And then dietitians we can phone on the day, and if they're available they will come, if not we do a referral. So that was the model before. Now COVID's happened. I'm lucky to work with such a great team that are so pro rehabilitation and really aware of PICS, and they've just done such incredible work so quickly to get this up and running. So the pathway now, and I'm going to talk about it, this is again from ICU discharge, this pathway. So once the patient's gone home, at 2 to 4 weeks from discharge home, they will have a telephone call from one of the doctors. And it's really sort of a screening consultation to see how they're doing. So checking all their personal details, seeing how they're doing, that they're safe where they are. And then are they okay then to be followed up 8 to 12 weeks later in our virtual clinic. If there's anything alarming at the time in terms of, extreme breathlessness, weight loss, issues with their swallow, or really struggling with their ADLs, need some social services input, then we flag that already and we'll put things in place. But otherwise, the next part of the pathway is to come to the virtual clinic. So we use Attend Anywhere, and it's a mixture really. consultant, nurse and the psychologist have been at the trust. I've been off site doing my part of it. I think what we're appreciating is that there's going to be huge numbers of patients that we need to get through. And we're working through the correct model and the correct pathway. And at the moment, I don't think we can say we've got it perfect, and we definitely need to work on the staffing model and the capacity, because what I'm noticing is for every single patient that we do the telephone consultation, which is an hour of us all trying to ask the questions that we want, I would say personally from a physio point of view, I now need to ring every single one of those patients back after to then ask more specific assessments, to carry on more education. But then this is the big thing, all the services that I normally would refer them to aren't there at the moment. So, normally I'd say I'll refer you to musculoskeletal physio, I refer you to pulmonary rehabilitation. Those pathways aren't there, they're establishing their services. So we've got the right ideas, but it still needs lots of work.
No, and I love that about you, Kelly. You're saying, look, we've tried this out, this bit's working, but actually this bit needs a lot of tweaking. And I think everyone's just sitting there listening in awe of how you guys, and I know it's very much a team effort, of what you've achieved there at Guy's and St Thomas's already. So, Bron, I want to bring you in at this point. So Kelly's just described beautifully there how there's a pre-existing model that's there. We've had to adapt this model to meet the needs of the patient demographics that are in front of us and the occupational, environmental challenges that exist in terms of access. Is it possible to provide a generic kind of framework for these patients based on the fact that, as Zoe said, as Kelly said, as my experiences, the experiences on the other podcast, of actually these patients do present with very similar traits? And what we do know, I can be, quite brave in saying that, and we don't think it's a pulmonary rehab model where people go to a class and they do, we don't think it's a generic resistance training model. We think it needs to address all of the different factors that we've talked about, which kind of is confusing because it is slightly a pulmonary rehab model where we talk about nutrition and cognition and psychology, and breathlessness and breathing dysfunction is actually quite high. So is it possible to provide a framework, number one? Number two, do we need a new guideline on top of the guidelines we've already got? Number three, how are we going to achieve this in the short period of time we need it ready for? Sorry.
No, remind me as we go through if I miss anything. So having it something that's nationally applicable to everybody, I think that is what we've tried, isn't it? That was the whole purpose of the NICE guidelines as well, was to have this framework for all ICU patients. And I think really the essence of what we see in the guidelines or the recommendations or the whatever it is you call them that's come out from various organisations, it is essentially building off the back of that. It's trying to capture patients, assess them, and make sure there's some kind of pathway or conduits for following up, and so that we don't lose people through the cracks. The challenges with something national is that whatever if we come up with something that we think is nationally applicable to everybody, it needs to be quite overarching, because at a local level services vary. So Kelly and I will know this. What happens in one London borough, the borough next door can be completely different. And they're two London neighbourhoods next door to each other, and the services will be totally different. And then if you put that across all of London, totally different. And then if you put that across the UK. So it's really hard to kind of say, this is what we should be doing, and this is where the patient should go, and they should go to this service and we'll call it this. And then they go to that service and we'll call that service whatever X it is. But actually, we need to give local clinicians the autonomy to be able to work with the local services that they have. And so that might be called one thing, it might look like something else elsewhere. So we need to be able to, I think, give local clinicians the ability to kind of work with the services that they know work in their own areas and which aren't necessarily the same across nationally. So whatever overarching framework we have, if that's indeed what comes out of all of this, I think needs to account for that, because we know when we've surveyed around post-ICU follow-up that it's completely ad hoc, geographically inconsistent and variable in terms of structure, format and content. So I think, you know, we need to allow for that. I think what we're seeing is pathways, which I think is a nice way of saying it, as opposed to different interventions that may or may not work for people. So you picked up around pulmonary rehab, and I agree. I don't think we should be blanket referring everybody to pulmonary rehab, and I think the pulmonary rehab teams would say the same thing, because pulmonary rehab is designed and is evidence-based and tested for bespoke populations. So we shouldn't necessarily expect that to work for post-ICU patients who are, as we've said, completely heterogeneous, much more complex in different ways with their needs than perhaps a more discrete group of patients with chronic respiratory disease. And I'm not suggesting they don't have particular needs, but you know, the system isn't necessarily just transferable. So there are probably things that we can learn from those service models. I think that might be of value in terms of how they're structured, how they're commissioned. There might be elements of that side of things that we can learn to help us with our rehab interventions. But I think kind of coming up with pathways that might work for patients is useful. I've obviously, without going into too much research, you know, the reasons we haven't been able to show that particular rehab interventions work for our ICU patients are multiple, and lots of them are methodological, because this is a very difficult group of patients to study. So what works in isolation, like Zoe's experience with her program, and we've seen isolated other programs that have local success, upscaling that in control trial conditions is very different, and that's a real challenge for lots of reasons that we won't go into here. But I think we need to leave the window open that we still have the opportunity to test specific interventions that might work with patients. So whilst we're designing pathways to use the existing services that we have, we still need to be mindful that we should be looking to continue to identify what treatments might be effective for patients. And that will take longer than looking at the short term, you know, trying to use whatever we've got locally available. And then my final comment was that I think Zoe and Kelly have both alluded to, is really, you know, using our community colleagues, the collaboration that's required that perhaps wasn't there before, not because nobody wanted to or nobody thought it was necessary, but if anything, this scenario now tells us that we really need to support our community services, whatever service that looks like. Whether it's community physio in the traditional sense, or a supported discharge program, or whatever it is, in whatever area you're in, we need to make sure that there is access back to the critical care clinicians, and that we give our support back to community clinicians, because they won't have seen these types of patients before. So regardless, I think this is a real opportunity to make sure that the pathway, in terms of a clinical pathway, is really improved by lots of those simple things: information provision, making sure that our colleagues are happy with what these patients look like. Let's not send people out into the community with just a written transfer handover and expect our colleagues to be able to handle that. That, you know, they're brilliant in the community, but we should be able to offer some support back.
No, you're absolutely right. And actually our experience, I mean, GPs are fantastic anyway. And I think, you know, the sheer time burden they have with patients is, you know, to achieve what they can in the short period of consultation times you do is incredible. But actually GPs are really coming forward now and saying, we want to help with this. We understand there's going to be a huge need in the community. What can we do? How can we work together? They're working in new models at the moment virtually, and they want to support these post critical care and post respiratory discharge patients. And you've touched on something really important there, and it's about the community therapists, community services that currently exist, because one of the challenges and the concerns that we have is the critical care clinicians, if you like, and the respiratory clinicians, is that we are learning about this disease the whole time. We see people who we think are physiologically stable, and then suddenly they deteriorate. And it's sometimes a gut feeling that you have when you're treating someone. We talked about this in the other podcasts, that you think, goodness, they don't look quite right. And then to put these patients in a community environment, potentially if we get to the stage of having face-to-face consultations or advising people, that's quite a difficult thing. Like, it boils down to the workforce. We suddenly need a whole new workforce of people that don't exist at the moment. What skills do they need? How do we train them? And how do we work together? So I love that idea, which is a very simple idea of bringing the two communities together, bringing the experts in the hospital, bringing the experts from the community and saying, we don't have your skills. You manage primary care, you manage this community care. We don't normally do that. These are our skills and that's what we can bring. You know, and that's really powerful, isn't it? And Zoe, do you think that's possible? Do you think we're going to get there?
I think, how cool would it be if at the point of hospital discharge you could have your patients risk stratified into certain groups, so you're not asking commissioners to pay, you know, one cost for everybody. You've decided who's most at risk, who's medium risk, who's low risk, and then you work with your community partners as to what they can offer, and you link the 3 up, or the 4 or the 5, whatever the stratification is, and that's how you match, and that's how you make, as Bronwen alluded to right at the beginning, that's how you individualize your recovery pathways, that you identify the risk, and you match it with what's happening in the community, and maybe that's why it's not worked before. Maybe because we've been trying to go for one model, or ish one model, and perhaps we've not really looked to our community colleagues to actually find what's out there, and if we have, it's different everywhere, as you say. So, you know, within our locality, we match our patients to what's available, and that's how we achieve what we're all trying to achieve.
Absolutely. And Kelly, you touched on it as well about the MDT. So we're all physios on this panel. You know, we're also allied health professionals, and you know, your team particularly at St. Thomas's recognises the individual contribution of the pharmacists, psychologists, dietitians, speech and language therapists. In the MDT podcast that we done, Sarah Wallace was speaking, obviously very experienced consultant speech and language therapist, and in the immediate acute phase, actually we're not seeing a lot of dysphagia, but we are seeing a lot of airway pathology, airway injury, repeated intubations, and the therapists I've spoken to who have reviewed patients post-discharge have described these swallow impairments, feeling like they have something stuck. I mean, we can't visualize the airway at the moment, so who knows what we will find when we start going looking again in terms of airway visualization. But actually, it's the whole team response, isn't it? It's the whole team input into these post-ICU pathways, clinics, so you can pick up these problems sooner, but also signpost and advise. So I suppose my question to you, Kelly, is for the teams that are listening out there who really struggle to get that involvement, what advice do you have, or you know, how can you use people's skills to help showcase the need, if you like, for them in the pathways?
Well, I think it's really important that, you know, we've got limited experience at the moment, but every single patient needs access to, like you've described, all of the AHPs. So we know that these patients with COVID have had issues with the food not tasting the same. We know that, you know, again, I need to learn more about it, the physiology personally, but airway edema has been a real problem with our intubated patients, and that's been a reason for extubation failure. How much of that is persisting? All of these patients are coming back with voice changes, and like we talked about, the issues with the swallow. So straight away, you've got your speech and language therapist and your dietetics colleagues in there. And I think one of the things that's really interesting is, because one of the cohorts of patients that have been, you know, a higher risk of getting COVID, they have been obese. And so when we're doing our phone conversations, it's quite interesting because a lot of them have lost weight when they're in hospital and have now gone home, and they're all saying that they're putting the weight back on again because they're just getting back to normal, or they're struggling because of the issues with the swallow or the voice. So I think there's definitely a role from a nutritional point of view that we need to get involved in, and that would also support them with the, you know, the musculoskeletal issues that they're describing. You know, like you were saying, they've lost muscle mass, they're really struggling with their normal daily living activities. they need to get back to work. Now that's a massive thing, which is why your occupational therapist needs to be involved, because it's talking to them about what sick leave are they on at the moment, have they got the right benefits, what funding have they got, what support can we offer for their employers, because they're having, you know, a lot of them are having employers putting pressure on them to come back to work. But again, work's not normal at the moment as well. So when you normally talk through workplace adjustments, how are we adapting to that? They need that support. So your occupational therapist, you know, is so valuable. And then what I would say is, from our experience so far, the role of the psychologist has just been huge, and that's for the patient. And a lot of the time when you do these phone calls, the family are present as well. And they all really benefit from that time that the psychologist can give them. And I think we touched on it at the beginning, just being able to say to people, even though it's not normal, but what they're going through is very common, and it's what people are all experiencing, and it's going to take time. That is the most valuable information that we can be giving these patients at the moment, and their families, to provide that reassurance when they're so isolated and we're not able to provide for them the services that we want to. So I hope that's answered your question, Rachel, in terms of basically everybody needs to be in follow-up clinic, because these patients really, really need it, and everybody's got such individual specialist skills that are really needed with this group of patients as we learn. And that's the thing that I just want to make really clear is I'm learning. I don't know the trajectory of this illness. I feel quite uncomfortable sometimes with the advice that I want to give these patients in terms of building them up from an exercise tolerance point of view and a muscle point of view, because I don't know how they're going to respond. And this is something that, you know, as time goes on, we're going to learn from more. But that's why we need the specialists in there at the moment, so that we can be doing the right assessment, identifying these impairments, and then looking at how they're progressing and how we best manage them.
No, absolutely. That's a lovely summary. And Bronwen, is all of this possible? Have we, is it a realistic target to have for these patients? Like, is it something that's achievable to have, like exactly what Zoe said, a framework, use the services that already exist, but work together? We're going to have to collaboratively work together, identify the needs, what's important, everything Kelly said, because not every patient is going to have the same need. Is this achievable now?
So I'm going to be optimistic and say I think it should be. I think there is enough momentum, and I think there are enough corners of the clinical community that are now, if they weren't before, are now aware of this as a real urgent public health priority. So we've talked, you know, we've all heard in the news about the different studies and the therapeutics and the urgent things that are happening to kind of treat COVID. But this recovery and survivorship is an urgent public health priority for the UK. And we won't know the true impact or the true cost of this pandemic. Probably we'll know it in the short term, because sadly mortality levels. We won't know about the long-term impact or the long-term cost of this until we start to see these patients in a year or 2 years down the line, and at time points between then. So I think that there is enough will to make this happen. I think that, as I mentioned before, whatever, you know, a framework that we may achieve needs to allow for localization, because we know that normal services are not the same across the board, let alone anything post ICU. So we have to let clinicians work within what they've got available at the moment, and then work towards models pathways that we know might be locally effective, or that at least allow patients to access the services that they need. I will put another mention in that I still think we need to be mindful. As Kelly said, we're learning so much about this condition, so much that we don't know, that we need to be very careful that we don't prescribe, you know, too much where we're not sure of what interventions would be effective. So pathways I think we can develop, but interventions we should still be mindful about testing, and still having a want to understand what interventions are effective from an investigative capacity as well.
I think that's just summarised this whole conversation up. So I am rehab. ICU rehab is not my thing. I am a self-proclaimed non-expert in this field, and my big plea to people, if you're a commissioner, if you're a manager that's listening to this, please get your experts involved. If you don't know where they are, then we can signpost them to you. We have the expertise, we have the willingness, we have the desire to make sure we get the best outcomes for patients who have survived this terrible disease. And we want to work together with everybody. We want to work collaboratively to help do the very best we can. And I think that in this moment in time is the very best that patients will hope for, that families will hope for, to know that we're working together to achieve realistic targets within the time frame for the right reasons. So I'm just going to come round everyone and see if there's anything else you'd like to comment on before we finish, or anything massive that I've missed. So Kelly, can I come to you first, please?
I think I would just say it's recognised that I know how lucky I am with where I work and the service that we had in place already. And there was so much work that went into that. And Bronwen, you led on that. So I think it's just reassuring staff that it is a big piece of work. There's obviously extra pressures at the moment, and then there's a whole nother level of factors. But it can be done, and I guess it's just saying, if anybody needs any support, I'm here to help with that, because it does make a huge difference, and it's one of my favourite parts to my job that I do. So yes.
Zoe.
Yeah, no, same really what Kelly said. Yeah, we're here to help where we can, and I'd say just start small and make a difference to a few, and then get bigger as you start telling their stories.
Fab. And Bron, final words from our rehab expert.
Oh God, what those two said. No, I think that we've probably covered off on everything. It's just, you can only work with what you have at the moment as well. And so the only way to do this is if everybody comes together and we try and understand what can we all bring, what do we have access to, and how do we make this work in our local areas for patients. And so, yeah, I think that's it.
Well, I just want to finish by saying thank you so much. I'm very late on this Sunday evening. I don't think people probably understand the amount of behind the scenes work all three of you are doing right now. And you're certainly not the first to kind of put yourselves forward and say that. So on behalf of everyone, our community, thank you so much for being as amazing as you always are. And yes, thanks so much for doing this. Really appreciate it. Thanks very much.